So we have a very exciting grand rounds today. Today we have our Badger Bytes, and this is a program that the research folks put together where we get to share exciting snippets of the research that's happening in the department so that people get an idea of all of the exciting things that we're up to. And every summer at the conclusion of the Shapiro program, we have our Shapiro students present what research they worked on over the summer. Most of you probably are aware of the Shapiro program, but this is a program through the medical school where students between phase 1 and phase 2 get to spend the summer working on research with faculty from the university. And it's supported in part by an endowment to the university and in part by the researchers or the departments. And each summer we have fabulous faculty who mentor students and wonderful students who get excited about research in our field, which is so important and so needed. All right, so this is the format. It's exciting. We need an exciting format at 7:30 in the morning, so we have brought it for you. This is based on the 3-minute thesis, which is a concept that came out of Queensland where researchers have to condense all of their research into one slide and present it within 3 minutes. We have made it a little bit more attainable for our students by allowing them up to 5 slides, although really it should be 3, and 5 minutes. So they're going to present their research, and some of them may not have results, but where they are in the process of their research now, they're going to present preliminary findings or their research question and methods. And then afterwards, there's going to be one facilitator question, and then we will allow questions from the audience. And if you're online, please throw them in the chat. We will read them aloud. We love questions. So the very first presenters will be online, and we will control the slides for you. So first up, we have Michelle Lynn, who is the student of Dr. Hoppy, who has 2 students, thank you, Dr. Hoppy, this summer. So take it away, Michelle.
Hey everyone, hopefully you all can hear me. So I'll be discussing today the effect of the Dobbs decision on sterilization rates based on location across Wisconsin. So you can advance to the next slide. All right, so the title of my presentation is The Effect of the Dobbs Decision on Sterilization Rates Based on Location Across Wisconsin. If you go to the next slide. All right, so on June 24, 2022, the U.S. Supreme Court's decision in Dobbs v. Jackson overturned the constitutional right to abortion established by Roe v. Wade, permitting states to set their own laws on whether to limit or protect abortion care. In Wisconsin, an 1849 law outlawed abortions once the Dobbs decision was finalized, resulting in a near complete ban on abortions across the state for 15 months. Clinics stopped offering services unless pregnancy was an immediate threat to a patient's life. In September 2023, a Wisconsin Dane County court ruled that the state's pre-Roe ban was not enforceable, and thus institutions like Planned Parenthood were able to resume providing abortion services. However, the structural barrier to managing pregnancy options may have impacted contraceptive decision-making. Because access to abortion care was limited in Wisconsin, many patients may consider other forms of contraception, including permanent sterilization, and early studies actually documented an increase in both tubal sterilization and vasectomy requests among both women and men in the months following the Dobbs decision. The objective of our study is to examine the rate of immediate and 3-month postpartum sterilization procedures in Wisconsin before and after Dobbs based on the geographic location in which patients deliver. Next slide. As for our study design, we did a retrospective cohort study of all births from January 1, 2021 to September 30th, 2023 in Wisconsin using hospital coding data from the Wisconsin Hospital Association. So pre-Dobbs was defined as January 1st, 2021 to June 23rd, 2022, and post-Dobbs was defined as June 24, 2022 through September 30th, 2023. Generalized additive logistic regression models were constructed for the change in the rate of sterilization at the time of birth and at 3 months postpartum as a function of geographic location. Statistical analyses were performed by biostatistician Ron Gagnon, and the study is IRB exempt. Next slide. So there were a total of 147,877 births in the study period. There were about 79,806 pre-DOBS and 68,000 post-DOBS. We saw 4.5% of people undergo immediate sterilization with no significant difference in the rates based on the DOBS decision. So there were about 6,679 sterilizations at the time of birth during the study period, with about 3,500 pre-DOBS and 3,000 post-DOBS. There was weak evidence of geographic variation in the impact of the DOBS decision on immediate sterilization, with a p-value of 0.15. There were nominally significant elevations in the rate of sterilization at the time of birth in 55 zip codes in southeast Wisconsin, and nominally significant reductions in the rate of immediate sterilization in 39 zip codes in western Wisconsin. Similar results were seen for sterilization by 3 months postpartum. As a result, the conclusion we drew was that the DOBS decision did not affect overall sterilization rates across Wisconsin. There is evidence of varying rates of sterilization based on geographic location that warrants further investigation. And then on the right there, you see a heat map that shows the estimated rate ratio post-DOBS to pre-DOBS in varying locations throughout Wisconsin. Next slide. As for next steps, we're currently planning on gathering data for 2024 from the Wisconsin Hospital Association to evaluate sterilization rates at 1 year postpartum. We hope to examine differences in outcome and time periods by race, ethnicity, and payer type. Ultimately, our data adds to evidence that location of residence impacts receipt of health services, and further analyses need to be completed to evaluate these subtle regional differences. The next slide. So thank you. Any questions?
Okay, I'm going to do a little trick that I learned from Elise Cowley, who's a MD PhD student who studied with me, which is when we do questions to put up the findings, because then people can look at the findings again, have time to digest them as they ask questions. I apologize for the echo that's happening. And then I have the first question, although I came up with another one as you were talking, but I'll share with the audience. My first question is if you can please explain how you defined sterilization for your outcome.
Yeah, so if you actually advance to the last slide, so I just added this final slide to kind of talk about how we included like the sterilization procedures. So initially we used diagnostic codes, and these are listed out in case anyone was interested. But we saw that the number of overall sterilizations were actually low. So we switched to using an encounter code for sterilization, which is Z30.2. And then we saw that there was an increase in the number of overall sterilizations, which seemed more in line with what we expected.
Is the encounter code for the consult prior to the sterilization or for the actual procedure?
I believe it's for the actual procedure.
Thank you. Questions from the audience, online or in person? Can you talk a little bit about the geographic differences? It sounds like overall you found no difference in sterilization rates pre and post DOBS, but you did note that there were some statistically significant differences in, is it just postpartum sterilization in certain regions?
Yeah, so it
was in
getting a lot of feedback. So it was the immediate sterilization. So right when they're still in the hospital, during the vaginal delivery or at a C-section, as well as a 3 months postpartum rate. As for the geographic difference, not totally sure why. I wonder if it's maybe due to like differences in insurance status or access to facility. Maybe a lack of knowledge of available resources. Like I'm wondering if people might have turned to other forms of contraception after DOBS because they were unsure of when abortion services were resuming. So I feel like more research is just needed to kind of figure out that difference in geographic variation.
Thank you so much. And thank you for, oh, we have a question up here. Yes, Dr. Lick.
In looking at rural or metropolitan areas,
Did you see any differences in sterilization rates based on if there was an actual OBGYN in the area versus a general surgeon? And that these people may not have had the opportunity to have someone who could actually sterilize them?
Yeah, that's a really good question. We didn't delve quite into what sort of providers were in each area, but I think that's something that would be worth looking a bit more into.
Very interesting point. Okay, any further questions? Thank you, and thank you so much for bearing with us and our technical opportunities.
Thank you.
Okay, so next we have Madison, who is going to be presenting post-operative complications following gender-affirming hysterectomy. And their mentor was Laura Hanks.
Hi, everyone. My name is Madison Seifer, and I worked this summer with Dr. Hanks looking at postoperative complications following gender-affirming hysterectomies, as well as Amy Godecker, our data analysis. Next slide, please. So for some background, it's becoming increasingly understood that gender-affirming hysterectomies are a vital part of life-saving care for transgender and gender-diverse patients. However, there's something to note. Their postoperative experience might be slightly different from their cisgender counterparts. Many TGD patients are amenorrheic prior to the gender-affirming hysterectomy, and because of this, they might experience significant distress due to the postoperative vaginal bleeding if experienced. Two of the outcomes we looked at to evaluate this difference were the level of healthcare utilization seen by TGD patients and the quantity of objective intra and postoperative complications occurring, as well as emergency room and urgent care visits. Next slide, please. So as far as evaluating these marks, we modeled our study after some colleagues at MCW, the Pando et al. Study that's linked below. We were testing to control the effects of some of the known potential confounding variables through a 1:3 ratio of TGD patients to cis patients. And for this, we employed various inclusion and exclusion criteria just to essentially approximate those two populations. I'll get into later why it's important to see that there are some objective differences in the way that these patients present. And then later we employed various statistical tests to obtain the significant findings from these data. Again, that was Amy Godecker, our analysis. Next slide, please. Thank you. So at the moment, I can only report on certain trends I've noticed while data collecting, but it's been interesting to see the role that gender dysphoria seems to play in the differences between gender-affirming hysterectomies and those performed for benign reasons. One thing I found really interesting was that the ages tended to trend lower around the teens to 20s for gender affirmation, whereas they trended higher for those being performed for benign etiology. And this is something we encountered with randomizing the cis population to the trans population to make sure that those not necessarily matched better, but that it was more comparable. And essentially, this is all we have right now, but I would love to share some findings related to the designated outcomes soon in the future. So thank you so much for listening.
Thank you so much for this interesting talk. My question for you is, what are the clinical implications of your study for surgeons who are performing gender-affirming hysterectomies?
Yeah, so I feel like there's a lot to be learned about gender affirming care in general. So I think it's important to understand the basics of what transgender and gender diverse patients are going through, not only in the moment of having the procedure, but everything leading up to it, all the barriers they encounter, and just kind of leading with the knowledge that they might have a different postoperative journey. And that might be why you might see more phone calls or more MyChart messages, because essentially the idea of bleeding out of their vagina is contributing to that gender dysphoria. And it is a real phenomenon for them, and it does freak them out. And so that's something to be aware of, and just proceed with empathy, really.
Perfect. Thank you, Madison. Any questions online or in vivo. You mentioned that you modeled this study after the study done at the Medical College of Wisconsin. How do you anticipate your findings will vary or not vary based on that study's results, and why might that be?
Yeah, so I know that for the MCW study, they had 88 TGD patients, whereas for our study, we ended up with 147. We looked at data from January 1st, 2016 to December 31st of 2023. So because we have a bit of a wider breadth of data, hopefully that will contribute to what they have already discovered. I think it will confirm a lot of the same trends as we're seeing. There is a similar incidence of surgical complication. And so it really comes down to how is healthcare being utilized in the post-operative time. I think that it'll probably confirm a lot of those findings that they found, but they didn't really delve as much into the post-operative time. And we looked at different time periods. So I think it'll be interesting to see if we find anything maybe more subjective with that experience.
Great answer. Thank you. Any other questions? Yes. We have one more question for you, Madison.
Thanks. So seeing that there's more bilateral oophorectomies in the gender affirming population, do you think that that could also lead to like a change in healthcare utilization between the two populations? Or like, are you going to do a subgroup analysis looking just at the women who also have the benign etiologies who get an oophorectomy, or like kind of a comparison with those?
That's an interesting.
Yeah, that would, yeah.
Like it.
Oh, sorry. That would definitely be interesting to look into. We, of course, like if someone is getting a bilateral oophorectomy, a lot of these patients are on estrogen afterwards, and that is a difference that we see from the benign etiology group. So it would be really interesting to see if there are similar levels of healthcare utilization in those getting bilateral oophorectomies, but on the cisgender side. So far, I haven't really seen many of them get onto estrogen afterwards. A lot of them tend to be more towards the postmenopausal stage of life. And so it would be interesting to look at, and that's definitely something we can think about.
Great question and observation. Next up, also online? In person. Oh yeah, okay, great. I will turn it over to Shrishti Gupta, who is going to be talking about ambulatory blood pressure monitoring in young adult women with and without a history of hypertension in pregnancy. And the mentor is also the good Dr. Hoppy.
Good morning, everyone. Thank you so much for being here and giving us the opportunity to present our work today. Oh, hey, Dr. Johns. I'm working with Dr. Hoppy this summer and my co-mentor, Megan Kanatsi Sinaisi, this summer. And I'm just going to get started. So as many of you know, hypertension is a serious medical condition that impacts women in all stages of their lives and significantly increases their risk of cardiovascular disease and other morbidities. Hypertension also affects 10% of all pregnancies and is a serious threat to the health and well-being of the mom and the baby. Unfortunately, many women with elevated blood pressures do not receive precise diagnoses. That is, they might be told they have chronic hypertension when they actually have white coat hypertension, which means that they have elevated blood pressures in the medical setting, but normal blood pressures otherwise. They could also have masked hypertension, which would mean that they have normal blood pressure readings in a clinical or medical setting, but elevated blood pressures outside. And this has direct implications for the health of the mom and if she's pregnant with the baby, as the diagnosis of hypertension can directly influence the medicine management, delivery plan, and the overall treatment of the pregnancy. The gold standard for diagnosing hypertension is ambulatory blood pressure monitoring, or as I may refer to it, AMBP testing. But currently there are limited indications for its use, and they've also been limited randomized controlled trials that evaluate its use in diagnosing hypertensive disorders of pregnancy. The MyHeart trial, which some of you may be familiar with, was a randomized controlled trial that evaluated the effect of health coaching on young adults with uncontrolled hypertension. As part of the screening process, they conducted ambulatory testing on all the potential participants. And we saw this as a unique opportunity in that we now have AMBP data for a cohort of people, of young adults who all think that they actually have chronic hypertension. And this is where my project comes in. So the objectives for my project were to assess the AMBP results in women who had the diagnoses of chronic hypertension and presented for consideration of enrollment in the MyHeart trial, and to determine if their daytime systolic, diastolic, or nocturnal blood pressure matched their prior diagnoses, and to also identify those women with a self-reported history of pregnancy, further define them by normotensive or hypertensive pregnancy, and determine if they received a correct diagnosis. So I just do want to mention that our secondary analysis was IRB approved, and the number is presented on the screen. So amongst all the people who presented for consideration of enrollment in the MyHeart trial, 513 completed the baseline AMBP monitoring, and amongst those, 221 were females. So we called all these 221 women and asked if they wanted to be part of our observational sub-study. If they agreed, an interview was conducted using a phone script where we asked them questions about their history of pregnancy, any hypertension-related conditions they may have experienced during their pregnancy or post their pregnancies, and any medication that they were taking during those times. After the screening, we had 55 women who agreed to be part of the study and also had a history of pregnancy. We worked with a statistician to analyze the data, and we used the R software. And for the purposes of this presentation, I'm just showing some of our results right now, but they're divided by 3 study groups, our overall study population of 221 women, those who had a prior pregnancy, and amongst those 55, those experienced hypertension during this prior pregnancy. And using their data, we'd classified them based on whether or not they actually had confirmed chronic hypertension, white coat hypertension, mass hypertension, nocturnal, or no hypertension at all. And just based on these results, it's remarkable to see that in all 3 groups, only around 60% of these women had confirmed chronic hypertension. The rest, around 30%, had a white coat, and some had MAST. So again, that table just highlights the prevalence of white coat hypertension, mass hypertension, and nocturnal hypertension in women who actually think they have chronic hypertension. It also highlights the importance of using AMBP monitoring to confirm the diagnoses of chronic hypertension, especially in women who are entering pregnancy with the belief that they have chronic hypertension. Currently, we're still working to assess the AMBP data specifically for the cohort of females who had a history of pregnancy. And one way we're doing this is by categorizing them based on the kind of hypertensive disorder they had, and then further analyzing their data. We're also working to assess the differences in individual systolic, diastolic, and nocturnal hypertension measures between the different groups. That's it. Thank you.
Great talk. I have a question, but I also came up with another one while we were there. So what are the current indications for those for use of the ambulatory blood pressure monitoring for people of childbearing age and those who are pregnant? And then what recommendations would you make for the utilization of it based on your findings so far?
So currently there are very limited indications for the general population and those who are pregnant. Certain cases where they do recommend AMBP testing if the provider suspects white coat or mass hypertension, or if the intent is to monitor antihypertensive therapy. But based on our findings, ideally, you would say that women of childbearing age who have elevated blood pressure readings should get AMBP testing to confirm their diagnoses, and especially, again, those who are entering pregnancy. But that comes with the caveat that AMBP testing does have limitations, whether it's access or cost. So even starting with home blood pressure monitoring would be a good start, just so that we are able to at least record the readings outside of a clinical setting.
Dr. Hartenbach?
I think mine was somewhat of a similar question. As I listen to this, I'm not surprised that the diagnosis didn't correlate. But it seems to me that this sounds sort of a larger alarm that, that we are not having accurate diagnoses for many people. And I'm wondering if the overall hypertension literature is moving in some direction. I know home blood pressure checking is much easier than it used to be, and obviously these kinds of ambulatory monitoring. So is there something happening in the non-pregnant population where, you know, we really ought to be doing a heck of a lot better job of defining these diseases? And so it seems to me, my understanding is, you know, a lot of people label chronic hypertension. That's just not the truth. And I'm just wondering, you know, if you could just briefly comment on trends in the larger hypertension literature.
Yeah. Again, when it comes to AMBP testing, there are research that says that it is recommended, and if you think that you've elevated blood pressure, then you should just get it. And the white coat hypertension has kind of become a fluff term where it's often women who show up claiming that they have normal blood pressure readings when they're back home are kind of ignored in that sense. And that's what the literature kind of points towards as well. But AMBP testing, given that it is a 24-hour period and it requires you to come into clinic twice, it's just not convenient for a lot of people. So it's just often ignored, and the office measures when in 2 different settings are taken for the diagnoses. So whether it's a general population or just childbearing women, the trends kind of are similar in the sense that there is a prevalence of white coat and mass hypertension, but there aren't studies that are specifically testing numbers. So which is why this is so unique in that we have AMBP data for women or for people in general, but also women who are of childbearing age and think that they have chronic hypertension and are being treated in some cases with that belief.
Multiple questions. Dr. Cutler.
Thanks for your talk. It seems like part of the premise here is that it's important to distinguish chronic hypertension from these other kinds of hypertension. So I assume that there is some evidence in the literature to suggest that the white coat hypertensives, the masked hypertensive, the nocturnal, don't have the same actual risk profile as those who have like a clear-cut diagnosis of chronic. So is that true? Like, should we really not care about the folks who do have white coat hypertension because we're not as concerned about their pregnancy risk? Or is there something going on there where we would still care even if their blood pressures are only elevated in front of a white coat?
That's a really good question. I actually read a paper recently that said that we do have to care because that also does have implications, but the risks are a lot lower and the way it would be managed should be very different. In case of white coat hypertension, there was a study that talked about just monitoring it further before we initiate hypertensive medication therapy or any therapy. Because for a female, for example, going into pregnancy, if she does have chronic hypertension, she's treated right away when she enters her 9-month period. But in terms of white coat hypertension, the treatment would be a lot delayed and a lot of monitoring would happen before any medication is started.
Did you see anything in the literature regarding white coat hypertension or masked hypertension? And if it correlated with undiagnosed anxiety? And if we're screening these individuals for anxiety as well?
I haven't come across that as of yet, but that's a really interesting point. But I haven't heard anything about it. Any other questions?
We do screen all of our pregnant patients for anxiety with a GAD-7, so you could look at that in our population if you wanted to.
Thanks.
Great job. Next, we have Estelle, who's going to be talking about referrals and abortion care. It'll just, okay.
So, good morning, everyone. My name is Estelle Ndukwe, and this summer I worked with OBGYN Dr. Abigail Cutler, bioethicist Dr. Paul Kelleher, and research assistant Corrine Hale to explore the roles of abortion referral systems in Wisconsin. For context, abortion is a common healthcare need, and 1 in 4 women have an abortion in their lifetime. However, studies show that only about 20% of OBGYNs provide abortions as a part of their practice. This leaves a significant number of patients who cannot obtain abortion care from their own OBGYNs. In survey studies, OBGYNs cite institutional structures and policies as one of the most common reasons for not providing abortions in their practice. And the 2022 Dobbs decision further restricted abortions in many states, including Wisconsin. So following Dobbs, institutional policies and institutional responses to statewide legal restrictions perpetuated disparities in abortion-related care, and most Wisconsinites who needed abortions had to seek out-of-state care and face significant barriers in doing so. So by the end of this presentation, audience members will better understand how abortion referral systems, or a lack thereof, affected patient care in Wisconsin following Dobbs. So as a medical student on the path of distinction in bioethics, I'm really interested in exploring whether institutions and hospital systems have an ethical responsibility to provide clear referral pathways for abortion care, especially in restricted states. And to begin answering this question, I sought to examine how Wisconsin institutions shape the ability of their OBGYNs to refer patients for abortion care using the data collected from a qualitative study led by Dr. Cutler and her group. And the data documented experiences of Wisconsin-based OBGYNs providing pregnancy care during a post-Dobbs statewide abortion ban. The qualitative study was collected in 2023, and 21 Wisconsin OBGYNs participated in open-ended interviews, and participants were recruited through professional networks using the snowball method. Physicians were eligible to participate if they cared for patients in Wisconsin at least 1 year before and 1 year after Dobbs. Interviews covered of various factors, including physician demographics, practice settings and scope, pregnancy complications, encountered and care provided, abortion referral processes already in place, and perceptions of institutional policies and responses to the Dobbs decision. Interviews were also audio recorded, transcribed, and coded for thematic analysis. So my sub-analysis focuses on study findings related to how physicians helped patients obtain abortion care. So first, we found that systems for facilitating abortion care vary widely across Wisconsin institutions, and physicians describe institutionally supported formal or direct processes and informal or indirect processes dependent on individual physicians. And then in some instances, physicians were left to find abortion care, or sorry, patients were left to find abortion care on their own. We also found that the absence of a robust referral system often contributed to delays in care and disrupted continuity of care. Physicians perceived this absence as disregarding patients' reproductive health needs as well. Participants received multiple factors or perceived multiple factors contributing to variations in referral processes across institutions, including stigma against abortion provision, institutional fear of political scrutiny, legal uncertainty and precarity, religious restrictions and conscientious objections made by institutional leaders or sometimes physicians themselves. Future directions include studies based on these preliminary findings. I'm hypothesizing that the lack of robust abortion referral processes may not only affect patient care, but also jeopardize bioethical principles of autonomy and justice and undermine physician responsibility to do good for their patients and cause no harm. For my next steps, I plan to apply a bioethical framework to the findings I've shared with you today to analyze whether institutions have an ethical obligation to implement formal referral systems to facilitate patient access to abortion care. Thank you for your time, and I'm happy to take questions.
Okay, for my question, what does the bioethics literature say about ethical obligations of institutions to provide formalized referral pathways for patients in need of abortion care?
So that's a great question. The ethics literature doesn't really say much about abortion care referrals, but there are articles on similar processes, such as how uninsured patients are being taken care of in the healthcare system as of late. And so I guess my next steps are looking into those articles and comparing them to the kinds of care that patients are receiving for their abortion care. And the healthcare need is different, sure, but the results similarly render patients without access to the needed care that they need due to institutional policy or design. And I plan on using these pre-existing examples as, how do I say it? I plan on using these pre-existing examples as a bioethical analysis moving forward. Oh, and how do you plan to take your analysis forward? So that kind of goes into my next question. Basically right now I'm looking at these articles and doing like a comparative side-by-side analysis of how bioethics literature has talked about the previous example I stated, and how it's similar to or similar or different in cases with abortion care, and trying to put that analysis together and come up with a statement on trying to put those together and come up with a statement on how ethics informs this type of analysis.
Questions from the audience?
Yes. Oh, perfect. So I said, thanks so much. The 21 physicians that you did the qualitative work with, I assume they were all general practice OB-GYNs rather than subspecialists. And then on the other side of that, has there been any work or is there any thought about extending this to some of our family medicine colleagues for patients that maybe don't have an established OB-GYN physician?
Yeah, so some of the physicians did work in family medicine or like general clinics. And maybe Dr. Cutler can say more about this, but most of them were OB/GYNs.
So online, she said that Dr. Cutler clarified that all of the 21 physicians were OB/GYNs. A small portion of them were maternal fetal medicine specialists. The majority were in general practice. Other questions? Yes.
Thank you for this talk. Were there analyses done on those particular reasons that you talked about that led to the confusion? I'm thinking specifically about the legal uncertainties, and was that also pinpointed to the location within the state where there may be less resources to help navigate some of those greater uncertainties?
So right now, in terms of location, there hasn't really been an analysis for it, or at least I haven't done any analyses for it. In terms of what you said, the first part of your question was the resources, or yeah, the legal uncertainties. When Dobbs first came out, everything was uncertain. Like you didn't really know what you could or could do, or what constituted as, because we went back to that 1849 law where it was you basically could only operate if the mom's life was at risk, right? And so no one really knew what that meant until institutions got together and made a rule. And a lot of the rules centered on miscarriages, PPROMs, and stuff like that. And that was the only avenue to perform an abortion. Now we've kind of gotten away from that rule, thank goodness. But there's still some legal uncertainty as to how an abortion can take place. There's a lot of restrictions in Wisconsin on how abortions can take place. And so Trying to look into the ethical implications of that and how that's affecting patient care is what I'm really focused on.
Perfect. Thank you so much. Good job, Estelle. And now we have our final presenter. Pelvic infection after egg retrieval in patients with endometriosis. Alexandra, I think, yes, perfect. You're in person, and Dr. Bhagavath is your.
Thank you. I worked with Dr. Bhagavath and Dr. Christina Dudley on pelvic infection after egg retrieval in patients with endometriosis. Sorry, how do I advance forward?
I think it's a matter of if this is here. Yes.
Okay, perfect. Thank you. Okay, so pelvic infection after egg retrieval is an uncommon complication. However, when it does happen, it's very serious. Patients at highest risk of pelvic infection after egg retrieval are those with endometriosis. When it comes to standard of care for who receives antibiotic prophylaxis, there's no widely accepted regimen across clinic to clinic. So some fertility clinics administer antibiotic prophylaxis to all of their patients, regardless of whether or not they have endometriosis. Generations was included in this cohort of clinics until midway through 2021, when the Infection Control Committee met and deemed that it would be appropriate to only administer antibiotic prophylaxis to the highest risk patients, i.e. patients with endometriosis. The antibiotic regimen itself has evolved throughout the time period covered in this study, but the current regimen being used for patients with endometriosis at Generations is 2 grams of IV cefoxitin and 100 milligrams of IV doxycycline on the day of procedure. This is a retrospective cohort study, and our sample is all patients who underwent egg retrieval at Generations Fertility Clinic between January of 2011 and September of 2023. That leaves us with 1,385 patients, all of whom have undergone between 1 to 5 egg retrievals. So our ultimate sample size for the number of retrievals undergone will be even higher than that 1,385 number. Our hypotheses for this study are twofold. The first is looking at endometriosis as a variable for pelvic infection. So we hypothesize that rates of infection will be low for all patients, but patients with endometriosis will have a higher rate of post-procedure pelvic infection than patients without endometriosis. The second aspect of this study is looking specifically at patients without endometriosis, so we're able to compare those who received antibiotic prophylaxis to those who did not. And we hypothesize that, again, rates of infection will be low for all patients without endometriosis, and that the rate of infection for patients who received antibiotic prophylaxis will be the same as patients who did not receive antibiotic prophylaxis. The Institute for Clinical and Translational Research helped start off our data extraction by using ICD codes to pull all the charts for patients who underwent egg retrieval at Generations during that time period covered in this study. They also helped with data collection for confounding risk factors such as diabetes mellitus status, BMI, age at time of retrieval, and antibiotic allergies. This summer, I've been working on manual data extraction. So I've been verifying all of the data that was pulled by ICTR. And then I've also been reading through all of the visit notes, my chart messages, and phone calls in the 2 weeks following retrieval to assess for whether infection occurred or not. I'm also documenting specifics of the retrievals and endometriosis if patients have it. So we've been looking at number of retrievals, oocyte yield for retrievals, endometriosis staging, whether or not they have endometriomas present at the time of retrieval, and the antibiotic regimen that they received. Next steps, we'll be working with Amy Godecker to perform statistical analyses on these results. And so far, data collection isn't complete yet, but I've reviewed roughly 1,000 patients. And again, all of these patients have undergone between 1 and 5 egg retrievals. So that number of retrievals is a bit higher than 1,000. And so far, there have been no cases of pelvic infection. This cohort of patients also includes the entire time period of selective antibiotic administration, during which only patients with endometriosis were receiving antibiotics, and there were also no cases of pelvic infection within that cohort. Thank you.
Okay, I'm changing my question. I have two questions. One, how did you define pelvic infection? And two, what did you consider a diagnosis of endometriosis?
Yes, so for the first question of how we define pelvic infection, we're looking at the 2 weeks following retrieval. And the first things I was looking for were any complaints of fevers or having visits with elevated white counts, and then provider concern for pelvic infection. And then more specifically, we're specifically concerned with peritoneal infection. So with egg retrieval, because you're putting the needle directly through the vagina, we're not concerned with things like endometritis or cervicitis. We're really just concerned about bacteria that's being introduced into that peritoneal cavity during the retrieval. And then, sorry, what was your second question? Oh,
What did you consider a diagnosis?
yes. So this was actually a point of discussion during the research. At first, we were, because how we're defining endometriosis and how it gets diagnosed has changed throughout the time period of this study, where diagnostic laparoscopy used to be necessary to officially define endometriosis, whereas later on, we can more confidently diagnose endometriosis with imaging on I believe ultrasound and MRI. So we're going mostly based off of the language that the providers are using. So if they received a diagnostic laparoscopy and endometriosis was diagnosed, we're counting that. And then also if they are, if a physician has performed an MRI or ultrasound and confidently said that they see endometriosis, we're counting that as well. And then we additionally have a caveat where we're documenting cases of suspected endometriosis, but not officially diagnosed.
I have so many more questions, but I want to take some from the audience. Okay, my next question then. But if someone else has one. One is, are you collecting, I know it's not your primary outcome, but secondary outcomes around things like cervicitis and endometritis to see if there is a difference? Two, if you've noted or if you're collecting harms from, potential harms from the medications that were provided, like adverse effects from the antibiotics. I'll start with that.
To answer your question in short, we're not specifically collecting those. Anecdotally, I haven't come across many cases of cervicitis or endometritis in that immediate 2-week post-procedure period. There are some patients who present with like more chronic endometritis, but we're not specifically looking at that.
Other questions? Anything online? Okay, last question. What is your hypothesis around, you have noted that you have not found any pelvic infections in over 1,000 patients. What is the baseline rate in the populations that were looked at previously? And what do you think it is that we're doing that is so great that other people should probably also be doing to account for the difference?
Yes, so Dr. Bhagavath and I were actually just looking at a study that shows that the baseline rate for pelvic infection is 0.4%. So in the 1,000 patients, again, because they've all undergone between 1 to 5 retrievals, even if we're estimating conservatively with that final number of retrievals, I've probably looked at close to 2,000 egg retrievals at this point. So we would expect to see around, if we're estimating around 8 cases of pelvic infection. And so we are confident that the power for this study and like the number of cases that we've looked at is sufficient. Dr. Bhagavath would be able to comment better on specifically what Generations is doing. The antibiotic regimen, as I mentioned before, has changed throughout this time period. So there have been periods where only Ansef was given, only Cefoxitin was given, and then currently we're using Cefoxitin and doxycycline. But yes, it's been exciting to find so far that there have been no cases of pelvic infection during this period.
Yeah. Initially, everybody was getting antibiotic prophylaxis. Obviously, the idea is to decrease chance of infection. There are practices that don't give antibiotics at all. And we sort of rolled into not being so radical and moving from antibiotics to everyone to selectively providing antibiotics only those with a history of endometriosis. And that's based on, as she pointed out, when infections do occur, it seems to occur only in patients with a history of endometriosis. So clearly, that's a predisposing factor in there. So perhaps we are covering our bases, whether we should move away from even providing them, because even with patients having a history of endometriosis, it's not that everybody gets it. So who gets it, who doesn't, is the question we can't answer. So perhaps being very selective is the most middle path in preventing infections after egg retrieval.
Any other questions? I learned something really interesting when I heard about this study, which is that they don't do, like, you think about infection control, you think about antibiotics, and then you think about like topical antiseptics, and they don't use those because of concern for harm to the, the oocyte, okay. And so that was part of the impetus also for using antibiotics. So that was interesting to me. I didn't know they didn't use topical. Okay. Great job. Thank you, everybody. Thank you to all of our presenters for your patience and your poise under pressure with our technical opportunities. And thank you to everybody listening and your great questions and your rapt attention. Thank you very much to our mentors for mentoring our students. And thank you to the students for joining our department for the summer. We've enjoyed having you. Thank you, everybody.